So I will talk and discuss with you today from biomarkers to precision medicine in Alzheimer's disease. And yeah, good morning, everyone. Here are my disclosures. Oh, it's a little bit slow, a lot of grants and also a lot of contracts. So in my talk, I will discuss the use of fluid biomarkers and a little bit state of the art on fluid biomarkers in Alzheimer's disease. And next, I will discuss with you how we think that we should develop novel biomarkers using proteomics methods. So the need for biomarkers. In Alzheimer's disease, we do need biomarkers because the disease starts already very early, maybe even 20 years before we see the clinical symptoms. So during this preclinical stage, we have a window of opportunity to intervene with treatments, but it also forces us to look for different methods to show that there is the disease ongoing, because we can't rely on the clinical measures yet. So, but luckily in Alzheimer's disease, we have such biomarkers, and we need them for the early diagnosis and also for prognosis, and lastly also for monitoring, because we still monitoring of treatment effects, for example. Because if we diagnose the patients in a preclinical stage, we rely on biomarkers, but then if we want to monitor treatment effects, even if it's 5 years before we normally can see the clinical symptoms, in a usual trial, you have like 1 or 2 years duration. So we still need to rely on biomarkers to give an objective indication of an improvement in the pathology. So that's why they are so important. And in Alzheimer's disease, we're lucky that we're able to measure the biomarkers, the core pathologies, the core proteins in the cerebrospinal fluid or by amyloid PET. So you're all aware of that, but it's very nice to summarize once more. We are able to measure the unique and characteristic proteins of Alzheimer's disease, which is different from cancer, where they have to rely on algorithms and some metabolomic changes. Which are difficult to show the specificity. But we are able to measure, the p-tau concentrations, which are elevated in the CSF, and they reflect tangle formation. And we're able to measure amyloid beta, the levels of which are decreased in the CSF, which is reflective of the plaque formation. And we can measure these proteins also by PET. But of course, we want to measure these also in blood. And luckily, nowadays, we're able to do so. So here's just one example from Lies Thijssen, a PhD student in our group, who showed that the plasma p-tau 181 isoform is specifically increased in AD. And this is measured by an ECL assay of AD Lilly. And in this graph, you can see that the levels in healthy controls at the left are relatively low, but they start to increase in the MCI patients, being highest in AD. And what's also remarkable is that the levels are higher in AD compared to other tauopathies. And this is not only true for plasma p-tau 181, it also happens for p-tau 217, 231. So different phosphorylated isoforms show this specific increase in AD. And they may be less good or more sensitive in early stage, but the jury is still out. I'm not yet convinced that it makes much of a difference, or whether there really is a biological difference between the different p-tau isoforms. It could likewise equally well be due to technical differences, for the assay having a higher affinity than others. So this is just one of the studies of Lies Thijssen, but you see a long list, and it can expand it even more because this is a result that has been repeated by many studies. So a very consistent result, and we can rely on it. And p-tau tends to be a very good biomarker also to measure amyloid positivity, but we do think that we have to measure multiple biomarkers. And why? Well, because those multiple biomarkers can give additional information. And here's one example. GFAP and neurofilament light, markers for respectively astrocytes and axonal damage, they are increased already early in the disease, and they are predictive of disease progression. So here we measured the GFAP levels at baseline and also neurofilament light levels. We measured them at baseline. And we divided the group in those who became demented at follow-up and who didn't. And you can see that already at baseline, we can make a good discrimination. So it's prognostic information that we derive from GFAP and neurofilament light. And you can see the same profile popping up if you do a Cox regression analysis. So we nowadays have multiple biomarkers to measure, both in CSF in the middle panel and also in blood at lower concentrations, and that's possible due to technological improvements. So the question could be, why do we still need novel biomarkers? Well, you can see at the left that Alzheimer's disease is not just amyloid and plaque pathology, but there is also inflammation involved, and that can vary along the stage of the disease. So we do think that we need additional biomarkers to capture the full complexity of the disease and maybe do some subtyping, so stratification. So patients who have more inflammatory phenotype or others have more astrocyte involvement or more blood-brain barrier damage. We have indications for that from our CSF studies that there are such clusters of patients, and they are predicted to react differently to different treatments. So we need more biomarkers. But we also need more biomarkers to address the other needs within dementia. There's often a heterogeneity in the pathological changes that we observe, but we also have barely anything to help other patients with other dementias, like Lewy body dementia or frontotemporal dementia. So we want to make a better diagnosis also for those dementias. And we need biomarkers also to measure the co-pathologies. So there are patients with Alzheimer's disease who have also alpha-synuclein pathology or TDP-43 pathology, which are the hallmarks of Lewy body and frontotemporal dementia. So we want to measure all those different co-pathologies because that's predicted to have to need a different type of treatments. So that was my introduction, the why. Why do we need novel biomarkers? And now I will address how we develop novel biomarkers using proteomics methods. Usually we develop it the development goes in different stages. So in the first phase at the left, we perform biomarker identification, for example, by proteomics methods. And then in the second phase, we do some initial validation in well-characterized cohorts against pathology, for example. And then in the third phase, if it's still successful, we do a lot of retrospective longitudinal studies. In phase 4, we do prospective studies, so we're closer to the clinic then already. And in the last phase is implementation. So there are a lot of action items that belong all those different phases. I won't address them here, but it's really a lot. And you can read them in our paper in Lancet Neurology beginning of this year. So this first stage, going from identification until test development, so for the retrospective analysis, we usually had some problems. So we performed our biomarker identification by mass spectrometry, and then we want to continue with immunoassay, because immunoassays are the method of choice for routine labs, but also for large-scale validation. And we had a lot of failures. So we thought of several solutions to address this. And one of these solutions is to avoid the technology switch, because we switched from mass spectrometry to immunoassay, so which is a completely different method. And maybe that was the cause of our problems. So we now want to go to do our discovery also in immunoassays so that we can smoothly translate panels of immunoassays to single immunoassays. And that's possible because we nowadays have different methods also for applying immunoassays for protein and biomarker discovery, for example, by the O-link proximity ligation assay. So we were able in the first data set to analyze more than 1,000 proteins, and they cover a diversity of mechanisms, but the panels are being extended, and nowadays you can measure even more proteins, up to a couple of thousands. But in our study a couple of years ago, when we initiated it, so you see it's still under review, so that's not yet finished, but almost. And we did a discovery study in CSF of different dementia patients. And it was an unprecedented large study cohort for such a proteomic study. So included almost 200 controls, 50 MCI, 230 AD, and 332 non-AD dementias, which consisted of FTD and Lewy body dementia patients. And we did the proximity extension assay. And in our results, we have two parts. We had two questions. In the first part, we wanted to know whether there are differences in mechanisms between those different clinical groups. In the second part, we wanted to work on translation of the panels. So doing a large proteomic study is costly. So we wanted to know whether we could make panels for further validation. And we did so by both custom Olink panels and also developing single immunoassays on different platforms. So here are the results. So with respect to the analysis of the proteome changes, we observed that there were many proteins that were upregulated in MCI patients, amyloid positive, so amyloid confirmed, and there were 92, and 20 proteins were decreased in this cohort. So more proteins were upregulated. And here you can see in a volcano plot how that relates to each other. So one of the highest were PARC7, IDUA, for example, and this is the fold change. And we plotted it against the Q value that's typical for such volcano plots. And with these results, we confirmed previous findings, so DDH1, ANO2, PARC7, which have been implicated already in MCI before, but we identified also numerous novel candidates like ABL1, SED4, and ENTPD5. So if we next compared AD versus controls, we had more proteins even. So 281 proteins were increased in AD and only a few were decreased in AD. And also here we had a lot of candidates that were familiar to us. You see ENO2 again, and MIF, for example, but also novel proteins. I'm a bit confused now. Yeah, this is my next slide. I thought it's so slow, maybe I missed one. Looking at those different changes, we put them together, the easiest graph is the middle one. Let's start with that one. So here we looked at the concentrations, the fold changes within the groups. So in the control, it's the reference, it's 0, and then in MCI, the majority of them were increased, and they remained increased in AD. So here is a cluster of biomarkers that are all increased and already early in the trajectory of development of Alzheimer's disease. And they were higher in AD and MCI and AD compared to the non-AD dementias. So these indicate disease-specific biomarkers probably. If we go to the left, here we see clusters of proteins that are changed only in MCI. You can see that. So it's here the highest levels in MCI, and the levels were about normal in the AD patients, like in the controls, and also non-AD patients. So that's interesting. So there are markers that are transiently increased in MCI or decreased. You also see a cluster of decreased proteins here. And at the right, you can see that there were also clusters of proteins that were slightly increased in MCI, but significantly increased in AD. So specifically AD in the AD dementia stage, compared to the non-AD dementia and also compared to MCI. So which mechanisms are they reflecting? So we did a GO analysis, and we found several mechanisms being involved, but there were also overlapping mechanisms. So I will show it here because the letters are very small, but by the symbols it may become a little bit more clear. So oxidative stress in the MCI and also in the AD, but apparently different intensity, different proteins being involved, but also protein clearance and lipid metabolism were also involved in MCI specific proteins, but also in the common MCI and AD proteins. Here we have some additional mechanisms that are involved. And markers that were specifically changed in AD, we also see overlapping mechanisms compared to the AD and the MCI ones, so the cellular remodeling and synaptic dysfunction, but there are additional mechanisms like immunity and vascular function. So here I represented them slightly differently. I don't know why my screen is so slow, but okay. So in MCI, we have oxidative stress, protein clearance, and lipid metabolism. Also in the MCI plus AD sets of biomarkers, but additional mechanisms like cellular bioenergetic, synaptic function, and intra and extracellular remodeling. And then in the AD specific changes, so not change in MCI and not change in other dementias, we have additional mechanisms like immunity and vascular function, and also some overlapping ones with the MCI plus AD group. So far so good. The mechanisms, to summarize, there are numerous CSF proteins specifically dysregulated in AD. We had the largest number in AD and not so much in MCI or in the other dementia specifically. I didn't show that now. And the CSF protein changes, they differ along the clinical continuum of AD. So some are already increased in MCI and continue to be increased in AD. So now the second part, can we identify translatable panels? And for the custom panels on Olink, we needed to have maximum 21 markers. So we did extensive modeling for the classification and modeled what would be the minimum number of markers that we need for the optimal change. And then the results show that we only need 8 biomarkers to make an optimal discrimination between AD and controls. And also for the other discrimination of the other groups, but I don't show the data yet here. We needed only 8 to 10 different proteins. So that's good news. You don't need too many, you don't need hundreds. And here are the markers that we identified. And these are then further developed on a panel. And here you see the discrimination, so area under the curve of 0.96, which is really high, and we also indicated the confidence interval. So, and the good news is also that these markers also reflect the different mechanisms that we, and all 4 mechanisms that we observed before in the mechanism analysis. So we next developed a panel, and we, for all the different discriminations that we were interested in, and we compared the fold change for the panels and in an independent cohort. So we compared the fold change of, for example, the MCI versus control in the left panel, left side of the graph. We compared that for the custom assays with the original discovery cohort fold changes. And here we had not such a good correlation between the fold changes for the MCI versus control, but still there is a kind of correlation. The R is 0.4. But for the other groups, other discriminations, we had a better and a good correlation between the fold changes. So 0.8 for the markers that discriminated AD versus control, and 0.87 for the markers discriminating AD versus non-AD dementias. So this graph is really key. It's showing us that our validation in an independent cohort replicated our previous findings. We also observed that in the areas under the curve. So on the top, you see the discovery that we did in orange, AD versus control, and the right side in blue, the AD versus non-AD dementias. We had an intermediate validation step because we had access to a cohort that had similar data, similar Olink panels run. And that was a smaller cohort, 62 patients only, but here also we had a good validation of our area under the curve already from that we observed in the discovery cohorts. And then we developed the custom panels and we did independent validation, so in different patient sets. And for the comparison, AD versus control, we again had a very high area on the curve, 0.99. And for the comparison, AD versus non-AD dementia, so the blue part at the right, we had the area on the curve of 0.80, so it's slightly worse than 0.87, but I think this is really a fantastic result. We next continued developing single assays. That takes a little bit more time, but it goes relatively smooth. Also because there is now a system, it's called the ELA system. It's kind of immunoassay and also microfluidics. And it has a big advantage that you can do your development and also the analysis quite quickly. With 3 hours, you have your results. We were able to develop and validate all those different assays, so those 5 assays for the panel for AD versus non-AD dementias, and that study of Katarina Bolshevik and Janaika Hokahin. So also here we are on our way for positive validation. So we developed the panels and we could also validate our original results in an independent cohort. So that's still ongoing work, and the ladies will present their work later on also. So it seems to work well. So the summary of our proteomics results are presented here. We identified and validated stage and dementia-specific protein panels, and these can be used as biomarker leads, but also have use for pathobiological leads to understand the disease in the very early stages, because pathology studies, they are very good and give us a lot of information, but we have to wait until the patient has died. Here we are at diagnostic area, in a diagnostic stage. And last conclusion is, for the panel development, applied workflow allows smooth translation and validation of our discoveries. And with this, I would like to thank all the people that participated in our center and our grantors. And that's it. Thank you very much for your attention. I'll be happy to answer any questions that you have. And if you don't have enough time, you can also mail me.
Thank you, Charlotte. That was a very clear presentation and quite exciting, I think. So I'm quite intrigued by the lipid effects, that you see them only in the early stages. Is that what you anticipated, or which lipids should we think of in this case?
Yeah, it's not lipids that we found, but these are lipid metabolism related biomarkers. But now yeah.
So these are either lipoproteins or lipid enzymes.
Yeah. Good question. So which proteins they exactly were, I don't know by heart now. So that's a bit difficult. If I was surprised, not really, because we know the cholesterol involvement. We know that there is some risk involved. ApoE is a risk marker, a risk gene for Alzheimer's disease. So it's not unsurprising. And maybe that we don't see it so much in the later stage is probably because all the mechanisms have taken over and masking the effects, inflammation, vascular injury. It looks like some more disastrous damage, I would say.
Thank you. Well, there are a couple of questions in the chat. So Michelle Hu has the question on potential targets, and ask you to comment on your experience of the importance of finding biological evidence of efficacy in humans through biomarkers before you embark on a trial.
Yeah, that's a very good question, and that's what we want to do in parallel studies. We define subtypes within the CSF also by a proteomic study, in that case mass spectrometry proteomic studies. So the next step is to, that's more like a theoretical exercise, because you need to do a large proteomic study. So now the next step is to translate those mass spectrometry proteomic study to a practicable assay like the immunoassays. So we want to compare the mass spectrometry data sets collected in the same cohort as we now did Olink, and we want to compare those different data, and hopefully we can use the signatures that we clustered before and for patient selection. And the real proof of the pudding is, of course, to do to apply these models in a trial and monitor whether the clusters have a differential effect. That's a bit chicken and egg. We need to have a good treatment. And we need to have access to CSF samples, and that's very hard for us. Most of the trialists are not yet able to share the CSF samples with us.
Do you think you will be able to move to blood-based samples within soon?
That's what I want. So in parallel, we also have a study. It's a JP&D funded study where we do the very same exercise, I would say, that we now did in CSF. So using O-link proteomics in a larger cohort, even 1,500 patients, larger panels also. And we hope that we're able to see the same kind of changes and same clusters, or maybe completely new clusters. Because I'm convinced that we see a lot of correlation sometimes for some of the biomarkers, but blood and CSF are different compartments with different kinetics. So I would be surprised if we see the very same clusters that we see in CSF back in the blood.
Yeah, we studied MMP10, and we see that in the adapted consortium, we see it in CSF, but not in blood, right? And others not in blood, not in CSF, vice versa.
Yeah, it has different kinetics also, but we do have the example of neurofilament light. That's very correlated between blood and CSF, especially in disease, not in controls. And but another biomarker like GFAP, it's not so well correlated between CSF and blood. So it's I think we need to study it and be open.
There's another question of Jill Ferrer. He asks how. For your 5-stage roadmap, what is the average time to go step by step?
Yeah, that's 20 years. So I would like to accelerate that. We can also see that for the plasma biomarkers, it's really an acceleration. They have been identified, the assays have been developed, and the first publications have been 2019. So I think that goes extremely quick because we're now starting with the real world prospective studies already. We will start in September. And we are exploring implementation in primary care. So it can accelerate if you have something really promising. And I hope that we don't wait those 20 years again, because that was the development time for the CSF biomarkers before we had them into the research criteria, only research criteria. But many people are using it already in the clinics. So on average, it's 20 years. So, but that's why we are developing all kinds of initiatives to accelerate this.
And I have two questions in one from John Todd. So about oxidative stress pathway. Did not get into your final biomarker panels. Is that correct?
Because I showed you especially the later stage biomarkers, and for the MCI panel it was, but we could not replicate that so very well, and it could be due to multiple reasons. It was the less powered, the least powered cohort that we included, so probably we need larger power there to make a better prediction of the panels. But also those mechanisms, and they are derived from what's known, and mostly it's known from cancer databases. So it gives us a help and an umbrella to a little bit understand, because we have such a multitude of proteins. But some proteins you could say that they're in cellular metabolism, but likewise in oxidative stress. I don't want to give too much value to each of the to those go analysis. It just helps us organize a little bit, and otherwise we get overwhelmed.
Okay, then there's another question of Laura Parkinen. What do you think of the roles SAA?
They're fantastic. They're fantastic. Now, for example, alpha-synuclein, it's a very promising assay, but it gives you only a yes or no answer. And we want to have quantitative measures as well. If you want to see an effect of a drug on the alpha-synuclein pathology, what will happen? Do we then go from the yes all the way to the no, and I'm afraid we need more quantitative biomarkers. And one of our biomarkers from CDSF proteomic study is DDC, which is elevated in DLB especially, and we also developed a good assay for that, and we could replicate our findings. So I have good hopes that DDC will be the alpha-synuclein, but then quantitative.
Yeah, and then one last question from Louisa. Some mediation studies of traditional biochemistry and novel metabolites suggest weaker intermediating effects of metabolites with CVDs and stroke risk. What might explain that?
I'm not an expert in metabolomics, and it's also because, metabolomics, I find it often very difficult to understand. And I'm looking into diagnostic biomarkers and prognostic biomarkers, and then they work better if it's really disease specific. And the metabolites are often not disease specific, and you have to look into profiles. And we have the good examples of p-tau, which is related to the Alzheimer's pathology. So so that underscores the relevance of protein analysis. So in the metabolites, it's good for risk factor identification and understanding of the mechanisms, but the effects so far have been very small. So that's good for epidemiology and understanding, but not for clinical practice. That's my view on it.
Thank you very much. I think this is all we have time for. So thank you very much, Charlotte, for this wonderful presentation.